Hello and welcome to the final episode of our Blood Cancer Awareness Month special series. Today we are focusing on the role of the multi-disciplinary team in the care of patients with blood cancer undergoing CAR T-cell therapy. This episode features expert insights from Ty Simpson, a CAR T nurse practitioner, and Frederick Vonberg, a neurologist with a primary research interest in the neurotoxic effects of CAR T-cell therapy. Finally, Angela Halley, who is a consultant in palliative medicine with an interest in developing early integrated palliative care in hematology, including patients undergoing CAR T treatment and stem cell transplant. This podcast is part of the CAR T and cellular therapy focus channel on VJ Hemonc. This channel is supported by Legend Biotech. These supporters have no influence over the production of the content. This podcast is intended for healthcare professionals only. First, we are joined by Ty Simpson. Thank you so much for speaking with VJ Hemonc. Can you begin by introducing yourself and your role in caring for patients undergoing CAR T-cell therapy?
Yeah, my name's Ty Simpson. I'm a CAR T nurse practitioner from the Alfred Hospital in Melbourne. My role in caring for CAR T patients often is usually when patients are first referred to our service. So making sure that patients have the right information at the right time and that their transition of care to our centre is as smooth as possible. Often after patients have been approved for CAR T, some patients require treatment between collection of their T cells and infusion, and making sure that that's on track and as seamless as possible, which is often very difficult and very complex. Also around educating families and making sure that the people supporting the patient outside of the organisation feel educated and have the right information at the right time to make sure that they feel safe in the community. Also, when patients are admitted, I have a role in educating not only the patient and the family, but the care staff that are looking after them. And once their acute period is over and they're discharged into the community, it's about ensuring that the family's best educated to make sure that the patient's safe. And then my role in the outpatient area is really around working as an advanced practice nurse, independently reviewing these patients and prescribing supportive care at the time that they need it.
Wonderful. Thank you so much for introducing yourself and the role of nurses in the CAR T process. So from a nursing perspective, what are the most important priorities before, during, and after infusion?
Before CAR T, it's important to establish what the requirements are, not only for the patient, but for the carer. So we know that patients coming into CAR T, there is a big responsibility on their carer. And so having that discussion at the beginning, oftentimes we're dealing with people that have aggressive or relapsed disease. So it's not only educating the patient on CAR T, but it's also helping the patient and their family understand relapse and what the next steps are. During the acute inpatient stay, it's around early recognition of toxicities and making sure that nurses, experts in identifying cytokine release syndrome and neurotoxicities, which we know happen in the first 14 days most of the time. And then once they're discharged again, they're back in the care of their loved one or support people. So making sure that they upskilled and trained in symptom management and identification of complications and what that escalation process is so that they can get the patient back into the service as quickly as possible. And then at the end of that, once the disease has been reassessed, it's about early referral and smooth transition of care back to the referring centre once it's safe.
What advice would you give to nurses working in centres establishing CAR T programs?
This is really exciting, and my biggest piece of advice would be around making sure that you work closely with your medical colleagues to design robust supportive care protocols. So if patients are having acute complications during their treatment, the conversation around how these patients are managed has already happened prior to them coming in. And so that there's a standard approach to complication management and recognition. Again, in the outpatient area, it would be around making sure that you have highly skilled nurses that are able to review these patients and provide supportive care. These patients are very different to anything else we've seen before. And so there really needs to be an expert nurse working in the area to oversee and coordinate the program.
Thank you so much for sharing your insights. Next, we are joined by Frederick Vonberg. Dr. Vonberg, it's wonderful to have you on the podcast. Please introduce yourself and your role in managing CAR-T-related neurologic complications.
Yeah, sure, of course. So my name's Frederick Vonberg, and I'm a neurologist who is part of a team who works very closely with colleagues in hematology and oncology and others, seeing patients who have neurological complications following CAR-T treatment. And so the most common condition that we see is immune effector cell associated neurotoxicity syndrome, or ICANS, and we have a big role in helping the diagnosis and management of that. But we also see other neurotoxic effects following CAR-T and conditions that might mimic ICANS. And perhaps we can talk about them a little bit later. But, as time goes on, our colleagues who, the treating teams for patients receiving CAR-T are becoming more and more comfortable with the diagnosis and management of ICANS. And actually, so, we've noticed that our role is actually where it's expanding is in the non-ICANS patients.
What are the most important signs and symptoms of neurotoxicity for all members of the multidisciplinary team to recognize, and how should they be assessed?
Sure, yeah. So for ICANS, that being the most common neurotoxic sequelae after CAR-T, we've got a good assessment tool called the immune effector cell encephalopathy score, or the ICE score. So that doesn't actually measure the most common features of ICANS, which are headache and tremor, but it's a very good bedside assessment to identify encephalopathy, by which I mean any sort of disturbance of brain function. And it's particularly weighted towards deficits in speech, language, and handwriting, which, for reasons we don't fully understand, are core components of ICANS. So patients will often have an ICE score performed by their treating team twice a day, and that will include a measure of handwriting. And often handwriting can be the earliest thing that deteriorates in ICANS. But I think the thing about the ICE score that's really important to remember is it's very, very non-specific. So any cause of cognitive dysfunction or encephalopathy after CAR-T will or is likely to make your ICE score drop. So any of these multiple mimics that people can get following CAR-T, they can all drop the ICE score. So although we define ICANS as being a drop in the ICE score, and that's right and good, a drop in the ICE score doesn't necessarily mean that a patient has got ICANS. So other things, most commonly we see delirium, which is a sort of non-specific encephalopathy that anyone who's in hospital is at risk of developing. This is a transient, fluctuant change in cognition and attention. Patients after CAR-T are very at risk of that for all sorts of reasons, including, infection, fevers, the cytokine release syndrome that they might get. And so that will all drop your ICE score and without necessarily implying that the patient has ICANS. The other thing I think is important to say, it's really key to identify and recognize the features of severe ICANS. So seizures and raised intracranial pressure are things absolutely not to miss. They're often quite obvious, particularly seizures, but not always. And, involvement of neurologists, I think, can help with that. And, all of this reflects the challenges here reflect the fact that with ICANS, we don't have any good biomarkers other than a thorough history and examination. And, one day that might change, but at the moment, lots of challenges come with that. So that's ICANS. I've talked about the features and the assessment, but there are some other specific neurotoxicities associated with CAR-T, particularly tumor inflammation-associated neurotoxicity syndrome, or TIAN. And that's where there can be transient neurological deterioration, which reflects localized inflammation at the site of tumor. And so that the features of TIAN will reflect where the tumor is itself. And that requires sort of prior knowledge of the tumor, where the tumor is located. But to work out whether the TIAN's going on requires a close and careful neurological examination.
How do you work with other specialists to diagnose and manage neurologic events? And what does effective coordination look like in practice?
Yeah, so the diagnosis and management of neurotoxic complications of CAR-T is thoroughly multidisciplinary team, requires a thoroughly multidisciplinary team approach. So, as I say, we work very closely with colleagues in hematology and oncology. My belief is it's important to be proactive in getting to know the sorts of patients they look after and getting to know the teams themselves so that you can give them an idea of the kind of things that you as a neurologist are able to offer and help them with. That's something, that I found very helpful. But, we also work very closely with other members of the wider team, both other specialty teams and allied healthcare professionals. So very closely with ICU, particularly if patients are experiencing very severe neurotoxicity. We work with colleagues in radiology, neurophysiology, and we work with the physiotherapy teams really closely. And I think having early multidisciplinary discussions with all these different groups is absolutely key. And then, rarely but importantly, we sometimes will involve other subspecialties within neurology. So I'm particularly thinking of colleagues in autonomic neurology here in the very, very rare scenarios where patients with ICANS can develop severe and persisting autonomic dysfunction.
For centres without on-site neurology, what practical strategies can ensure rapid, high-quality neurologic assessment and intervention?
Yeah, so I think as with all management of all neurological conditions, often a lot of information can be obtained over the phone, which can help to guide diagnosis and management. I think the key thing when someone is seeking remote neurology advice, to make that advice as helpful as possible, is to provide as much information as possible from a thorough history, and often to provide the findings of an examination. So, I think, as we've talked about the limitations of the ICE score, I think phoning up a neurologist and saying the ICE score's dropped is often not providing enough information. Sometimes going a bit deeper and working out the exact ways in which someone's cognition has deteriorated is going to be really helpful, particularly in working out whether a patient might have ICANS or one of these many mimics. And then brief examination, I would say brief but thorough examination of the patient, can also provide a lot of information. That's key in ICANS, but particularly important for this phenomenon of TN, where the localization of the neurological deficits is really key in making the diagnosis and quantifying the degree of deterioration. And then the other thing I would say for centres without on-site neurology, don't be afraid to escalate early. Colleagues in the intensive care unit can be extremely helpful when patients seem to be deteriorating.
Finally, what key lessons have you learned about preventing and mitigating long-term neurologic effects in CAR-T patients?
So prevention is a very active area of sort of ongoing research. The one thing we know that increases the risk of developing ICANS and of developing severe ICANS is having a high prior tumour burden. And, teams who give CAR-T are well versed in reducing that tumour burden for this reason. There are various studies going on of, prophylactic or early interventions, but we don't have a clear answer on prevention yet, but that's a very exciting field. But mitigating ICANS and other neurotoxic syndromes, since my involvement with these patients, the thing that I've really come to realize is that there are significant side effects associated with the treatment of ICANS. So ICANS is treated with steroids and sometimes with anakinra if it's severe. And, if what you're treating is ICANS, that can often be a very effective treatment. But if what you're treating isn't ICANS, but just looks a bit like ICANS, those steroids can do lots and lots of harm. And often they can make patients neurologically worse. And if that is again misdiagnosed as being ICANS, the steroids are often escalated, and you can end up in a vicious cycle where patients tend to do very, very badly. So this all comes back to the really key importance of misdiagnosing a neurological deterioration as ICANS when you don't have good evidence. And remember, these patients who get CAR-T have got any number of reasons to have a neurological deterioration, like the delirium I've talked about, but they're also at risk of central nervous system infections. So getting it wrong has serious implications, and that's something that early involvement of a neurologist, I think, can help with.
That's everything. Thank you so much, Dr. Vonberg. Finally, Angela Halley joins us. Dr. Halley, can you begin by introducing yourself and the role of palliative care for patients with blood cancer undergoing CAR-T therapy?
My name's Dr. Angela Halley. I'm a consultant in palliative medicine, working at the Royal Marsden Hospital in London, which is a specialist cancer hospital. We look after patients with all kinds of cancer, including blood cancers. I've been reviewing patients who are about to have CAR-T therapy since we started delivering this treatment in 2020. I and now my broader team aim to review all patients who are about to undergo CAR T treatment. The purpose of this is to discuss their current symptoms, talk through the CAR T treatment, and start to talk about advanced care planning. Advanced care planning is a term that we use to describe where patients with a potentially life-limiting disease start to think about what matters to them and begin a conversation with their families and healthcare professionals about their wishes for the future and begin to put in place any practical affairs that are needed. This might be practical affairs about caring for dependent children or older parents, financial affairs, or just their wishes should they not be able to share their wishes if they were very ill in hospital. I now have a team that's a dedicated nursing team that reviews patients who are about to undergo CAR T therapy from a specific palliative care hematology service. And we're just exploring how that works with the current hematology team.
You have been an advocate for early integrative palliative care in hematology, including for patients receiving CAR T therapy. Can you walk us through what early integration looks like in practice and why it's particularly important in the CAR T treatment pathway?
Early integration means that our involvement is standardized and normalized. We see our role as part of the broader hematology team of doctors and nurses that are caring for patients. Working together with hematologists means that the patients receive the best care, as we can understand what they've heard from the team and use that information within our consultations and have a more joined-up approach. We recognise the importance of this approach within CAR T as the treatment has an uncertain outcome and is usually at a significant crossroads in their treatment journey. We are aware that new treatments are being continually developed and outcomes changing, but usually CAR T treatment is used when other treatments may have failed. Also, the treatment, CAR T, which they're about to undergo, can have some significant side effects, including making them feel unwell and impact on their brain functioning, albeit usually temporarily. From our experience, patients and their carers have found benefit in meeting a palliative care team during the preparation time for CAR T. It's given them an opportunity to start to explore their future needs within a parallel planning framework. That means we're hoping for the best, but also preparing for the worst.
From your experience, what does good communication look like within the multidisciplinary team caring for CAR T patients? Are there any systems or practices that you found particularly effective to ensure good communication?
For me, good communication looks like clear oral and written communication, which meets patients' needs and addresses their concerns. Also, what is usually very important to patients is that members of the team are all familiar with their situation and share relevant information with each other so that frequent repetition is not needed by the patient or their family. We have found that preparing patients prior to seeing us in a consultation with a written letter or telephone call to explain the purpose of meeting us is most helpful. Therefore, the patients are aware that they may be having a sensitive conversation about their wishes for the future and discussing their current symptoms. Also, sharing relevant discussions with each other and the community services, including the GP, means that everyone caring for the patient has heard the patient voice. Another way of sharing information with one another is the use of electronic shared care records. These can be a useful way of sharing information between different services. These mean that if a patient needs advice out of hours from a community-based service or a GP or an ambulance service, there's already information available about the patient and any decisions they may have made, their current treatment plan, and some description of the healthcare professionals involved in their care. These are different around the country and dependent on people's areas, but this is often something in which palliative care teams may ask patients, would they wish their information to be shared in an electronic shared care record for community use. The other way in which we share information is multidisciplinary meetings within the hematology clinical teams, and we join those meetings as a palliative care team to ensure we hear what's going on about the patient and therefore improve information sharing.
What are some of the common barriers to fully integrating palliative care into the CAR-T treatment journey, and what practical steps can teams take to overcome them?
So we often see common barriers in all blood cancers, but particularly lymphoma, which is often what patients have who are going to have CAR-T treatment, are the unique disease characteristics of those blood cancers. So those can be an unpredictable disease trajectory with new and emerging treatments, and often a lack of distinct transition from curative to palliative intent. Patients also have strong and long-established relationships with their hematology teams, so including another team can be challenging. The other huge barrier is that perceptions of palliative care can be, people feel that's synonymous with end-of-life care and can be very frightening for patients and even clinicians. Patients may feel that this is at odds with the curative intent of CAR-T treatment, and clinicians themselves may feel that referral to our team is only necessary at the very end of life. I think recognizing those barriers and trying to overcome them by having early integrated teams makes our involvement standardized and normal, and takes away any differences or gatekeepers in referral and changes our role within the team. We also have a role as palliative care clinicians, whether that be nurses or doctors, to explain what we do, why we're there, and how we can support patients and how we fit into the broader team. So I think we need to better understand the needs of patients by speaking to them and speaking to clinicians, but also be aware of these barriers and try and demystify those with patients when we see them.
That's all of my questions. Thank you so much for joining us, Dr. Halley. We hope you enjoyed today's episode. Be sure to follow us on X at VGHemonc and subscribe to our podcasts on Spotify, Apple Podcasts or Podbean so you never miss an episode. Thanks for listening, and we'll see you in next week's podcast.